this event is the role of nurse practitioners and PAs, leveraging opportunities. And we are joined by two um, representatives from the MLMIC Insurance Company, Elizabeth Olenek, who's an attorney in the legal department, and Deanna Miro Altman, who is a risk management consultant downstate. Before we get started and I pass it over to them, I just wanted to let you know a few housekeeping things. Everybody is muted. This is a Zoom meeting. You are muted upon entry, but at the end, if you would like to ask questions, you have the option to use the chat. We welcome you to do so. Or if you would like to ask a question, you can raise your hand to be asked to unmute. And there's also a CME evaluation that's available at the end to claim CME. So that will, when the meeting closes, it will open in your browser. And I will also put in the chat a link to the survey as well, so that you make sure that you can take that. And at the end, we will share some more information about other events we have going on this week, because it is our advocacy week, and other ways that you can get involved with the chapter. We're so glad that you're here. And with that, I will pass it over to the main event. And I think Deanna is going to kick us off.
Thank you, Amanda. I appreciate it. And I also want to do a shout out to Loretta Panesi as well for having us here today at your Advocacy Week. Really relevant topic. We've got a lot of feedback on this program. So, I hope at the end we'll be able to answer some of your questions. But we really do appreciate you taking your lunch hour, or maybe you're answering, your 10,000 portal messages and we're on in the background. But either way, we appreciate, you being here with us today. And we'll get started. Do know the presentation is being offered for informational purposes only. It does not constitute legal advice. And we always recommend you consult with your attorney should you need assistance in the application of any of the material presented to you today. The statements you hear are solely ours as presenters. And as long as we have your email and your evaluations today, you'll get 1.0 AMA PRA Category 1 credit for your participation. And once again, we thank you for that. Elizabeth and I are employees of MLMIC Insurance Company, and we do not have any relevant financial relationships to disclose. We always like to thank our planning committee for their participation in all these educations events that we do get invited to do. They too have no relevant financial relations to disclose. So in just under an hour, you'll be able to differentiate the scope of practice for nurse practitioners and physician assistants. You'll be able to interpret MLMIC MedPro claims data for nurse practitioners and physicians assistants, evaluate those common allegations that are asserted in medical malpractice cases that include NPs and PAs, as well as apply some risk management principles and best practices to incorporate these professionals into your practice. Now, these clinicians have been part of American medicine, since the 60s. In the past, we've called them physician providers, allied health providers, physician extenders, mid-levels, which really is not the most flattering, thing to be called, I think, but, and more recently, advanced practice providers, as well as advanced clinical providers. MLMIC recognizes, there are distinct differences in how these providers practice at their, top of their licenses. For today's purposes, we're not going to use clump everyone in as an advanced practice provider. The PA Society is actively pursuing a name change for these professionals. I believe Oregon already has adopted the name change from a physician assistant to a physician associate. But, today in New York, physician assistant provides medical care under the supervision of a physician, and the range of care does fall within the practice of the supervising physician. Nurse practitioner is a registered professional nurse who has completed advanced nursing education. They may become independent after 3,600 hours of experience, and they maintain certifications in a wide range of specialty areas. Looking at New York state licenses over the last few years, with the exception of 2022, the number of PA licenses have steadily gone up. Nurse practitioner licenses have almost doubled in the last 5 or 6 years. So really lots of growth here. We'll take a look at some data. So here we're looking at the overall case volume for New York State data for the top 5 primary roles with MLMIC MedPro cases open from 2012 to 2021. And as the role of PAs and NPs in healthcare has increased, together we see nurse practitioners and physician assistants are noted in 18% of our clinically coded cases, with attendings and consulting physicians being most prevalent at 65%. Now, the number of cases by year should be viewed from a couple of different perspectives. One, that the enhancements to the coding taxonomy over the years really has allowed for a more definitive identification of NPs and PAs as service roles in the case. And also that we see a decreasing number of cases in later years, and this is more likely due to those cases that have yet to mature for coding. We do see an unexpected decline, 2020 to 2021, likely related to the pandemic as well as social inflation. Now, the data here reflects the percentage of cases opened each year, and it does note a high clinical severity outcome has been pretty consistent across the board. As the number of PAs and NPs are increasing and likely taking on more complex patients, we do see the cost to resolve these cases have rapidly increased. Once again, we have to consider social inflation. We have to consider plaintiffs' attorneys. They're being very selective. They're seeking those cases with big monetary relief. Those nuclear verdicts are contributing to the rapid increased cost to resolve these cases. The distribution of PA cases by location over time has been pretty consistent in these areas: the office clinic setting, the emergency department, the inpatient or ICU area, inpatient surgery and recovery, as well as ambulatory surgery. Now, this is something we'll be watching as scope of practice and regulations are changing for these providers. As NP roles have changed, we look at NP case distribution by location, and we do see an increasing percentage of patient room ICU area cases in the golds against the corresponding decrease in office clinic cases. From 2013 to 2022, obviously, lots of role changes of NPs and regulation changes in these practice settings, have contributed a bit to this. Now, location data are pretty consistent nationwide versus New York State for that overall percentage of case volume. Looking at PAs and NPs, the percentage of PA cases in the emergency department or the urgent care setting is higher in New York State at 26% than across the country at 23%, as is the case for NPs, 20% in New York State, and across the country, 15%. Now, this could account for the greater number of NPs and PAs that are being utilized in New York State emergency departments, whether it be a lack of adequate access, especially in those rural areas, as well as the ER being used as a primary care location in some metropolitan areas. We do see a greater volume of cases where there is the least physician direct supervision and lower clinical acuity in the office or clinic setting. Nationwide, 47%, in New York State, 42%. As we look at NPs in New York State in the office setting at 50% and PAs in New York State at 39%, and likely due, to that autonomy and the increased number of NPs practicing in that setting. We'll take a look at some claims and contributing factors. Looking at contributing factors nationwide, it's not just one issue that leads to these cases, but there are multi-layered issues or failures in the process of care that somehow appear to have contributed to the patient outcome or the initiation of the case, or just somehow had a significant impact on the case resolution. The employment model for PAs and NPs may affect whether it be a lack of, affects risk, whether it be a lack of understanding of the roles and accountabilities, difficulty engaging in a team-based practice or collaborative practice, or lack of clarity from a supervising physician. With the exception of supervision and technical skill, overall, there are relatively few differences between NP and PA case volume of contributing factors in both the nationwide as well as the New York State data. Across the nation, insufficient supervision and oversight is present in 35% of all NP and PA case volume. And in New York State, 36% of cases identify technical skills. And this makes it really the third most common New York State factor. PA involved cases with technical skill issues and supervision issues is noted to be reflective of the high percentage of PA involved orthopedic surgery cases. Now, there's a slightly wider disparity of cases involving clinical systems in New York State between NPs 24% and PAs 13%, as opposed to 17 and 12% nationwide. These things would relate to coordination of care, the failure or delay of ordering tests, reporting findings, as well as, follow-up systems. Elizabeth's going to get, more detail with contributing factors when she discusses a case study. But here we're looking at cases in which a clinical judgment factor is specifically linked to either an NP or a PA. Errors in clinical judgment are the most common contributing factor. Overall, that failure to appreciate signs and symptoms, test results is the most prevalent overall and broken down into these three areas: your ambulatory, inpatient, and emergency setting. Now, many have argued that PAs and NPs order unnecessary testing. However, we see in the ER in New York State, 40% of our clinically coded cases are a failure or a delay in ordering a diagnostic test, and 32% in the nationwide data. And often these system failures represent many small mistakes that ultimately lead to that one big mistake and results in a claim. Inadequate assessment resulting in premature discharge of care is present in 32% of the cases in the emergency room as well. Looking at the numbers and given the increasing autonomy of nurse practitioners, more of the supervision issues are attributed to PAs. Things like physicians sign off on charts without review or participation of care is a noted concern, especially, in the emergency department. 82% nationwide and 75% in New York State. Now, supervision plays a role in medical malpractice cases with both direct and employer vicarious liability. Elizabeth will get more into detail and take a closer look at this, shortly. It sounds a bit doom and gloom, but it really isn't. MLMIC partners with Candelo, which is a national, medical malpractice data collaborative and division of CRICO, the medical malpractice insurer for the Harvard-affiliated medical institutions. And Candelo looked at about 65,000 cases in 2023, and PAs, accounted for 4.7% of the claims, and NPs 3.9% of the claims from the period of 2012 to 2021. So really, lots of good things, not a lot of cases from what they looked at, but, it's a good time. We'll take a look at some of the benefits of these professionals and having them part of your team. Now, if current trends continued by, 2034, the projected physician shortages will be somewhere between 17,000 and 48,000 in primary care alone. 2/3 of the healthcare providers joining the U.S. workforce in 2030 will be an NP or a PA. Now, physician interactions with nurse practitioners and physician assistants are expected to increase in frequency. And as of 2022, NPs and PAs do make up a larger portion of primary care providers than physicians. so many great benefits to have, these professionals part of the healthcare team, bringing qualified individuals into the workforce in less time, being able to optimize that workflow through top of the license initiatives. It allows physicians more time to treat those complex patients. We're in a very market-driven environment right now. Academic medical centers, hospital systems, organizations are really seeking to leverage PAs and NPs, not only to boost revenue and productivity, but by having physicians focus their efforts on managing that increasing complexity of patients. Nurse practitioners, physician's assistants, they deliver comprehensive care. They promote preventative health and lifestyle changes. They collaborate as members of the healthcare team. They're increasing access to care, providing continuity of care, as well as educating patients and supporting physicians overall. Statistics do indicate that PAs and NPs generally provide high-quality patient care. Their patient satisfaction scores are similar to physicians. They're not meant to replace physicians, but, provide physicians with, like I said, more time to look at those complex patients. There's ever increasing demands on physicians, on hospitals, on health systems to improve patient satisfaction, manage costs, reduce costs, and improve quality and access to care, particularly in those rural areas. And all these forces, are pushing towards a collaborative team-based care model and leading to more autonomy for both PAs and NPs as well. Quality of care of these, providers have been shown to be very similar to physicians for those routine patient presentations, and just being able to get people into the workforce sooner with that less financial stress of medical school, specialties without having to commit to a residency or all benefits of these providers. Overcoming the primary care shortage, is likely going to involve a coordinated team-based effort from physicians and PAs and NPs. Right now I'm going to turn it over to Elizabeth. She's going to get a little bit more into detail about, physician's assistants as well as nurse practitioners. Elizabeth?
Thank you, Deanna. I'm going to first discuss some of the legal parameters of the areas of NPs and PAs and some of the areas of liability, and then get into a case study. The PA profession is growing exponentially, and this growth is expected to continue. The profession is expected to grow 27% between 2022 and 2032, with approximately 39,000 jobs added. This growth is actually higher than 3% average growth of all occupations. The PA profession is also very popular. Employment for PAs has been high up on the best STEM jobs list for the past several years and is currently number 3. Right now in New York State, a PA is a dependent practitioner, which means they must work under the direct supervision of a physician. And the scope of the PA's practice is limited to the tasks that are delegated by the supervising physicians. The physicians can only delegate tasks that are appropriate to the PA's education, training, and experience, and within the ordinary practice of the supervising physician. Pursuant to New York law, a supervising physician must be immediately available while the PA is providing medical services. Now, this doesn't mean that they have to be available physically in the office. It means that they have to be available at least by phone and immediately available for a phone call. And again, this is because the physician is responsible for the medical care the PA provides. It should be noted that inadequate supervision for PAs may result in allegations of professional misconduct. And the legislation that was recently signed and went into effect has changed the way PAs can practice in the state significantly. So I'm going to get into that in some detail. In November 2024, the significant legislation was signed into law, and it will change the way PAs practice and improve access to care for New Yorkers. The law went into effect beginning February 22nd of this year. And notably, under this new law, a physician in private practice may now supervise or employ up to 6 PAs, which is an increase from 4. They can also supervise 8 PAs in practice for the Department of Corrections. And the law also states, this is a significant change, that hospitals may employ an unlimited number of PAs, provided they work under the supervision of a hospital physician and within that physician's scope of practice. This is a change from the prior limit of 6 PAs per 1 physician. This new law also expands the PA's role to prescribe non-patient specific regimens to registered nurses, to write inpatient orders for durable medical equipment, and to supervise radiologic technologists administer contrast media. Getting into the liability of a physician for the actions of a PA, it's important to know this when we're thinking about legal malpractice. The supervising physicians can have direct liability for their own actions, which may include negligent supervision of a PA. The factors that the courts consider to determine whether a physician has provided appropriate supervision includes the presence or absence of the physician. Was the physician immediately available at the time the incident occurred and available as required by law? Responsibilities that were delegated to the PA. Was the PA doing something that was within their scope of practice, something that was actually delegated to them, that was within their experience? And the courts will look at medical record documentation, what was documented about the incident. They'll also look at whether the number of PAs being supervised at the time of the incident was within the maximum number allowed by law, which we now know from discussing the new legislation has been increased. Supervising physicians or hospitals may also face direct liability for allegations of negligent hiring. If the hiring individuals, the people at the facility or the supervising physician who determined that the PA can be hired, knew or should have known that the PA was unqualified or otherwise unfit to perform the professional services signed, they may face negligent hiring. They could also face liability if they failed to use due diligence to ascertain if the PA was capable of performing the assigned duties. And again, this is direct liability. The PA would not be considered liable in these cases. Physicians assistants can also perform actions that result in vicarious liability for the supervising physician who is supervising the PA in the instance of a negligent act. This is called respondeat superior. So if the PA performs negligent acts and it is determined that the supervising physician could have directed their activity, the physician may be found liable for the actions of the PA. In order for this to be the case, the patients must reasonably believe that the PA had the authority to act on behalf of the supervising physician. And the physician, it's very important to note that the physician does not even have to be present or aware of the patient encounter for vicarious liability to attach. Legislative efforts continue in this area to allow experienced PAs to provide care without oversight. Right now, they are dependent practitioners. And there's arguments for and against some level of PA independence. MLMIC does not take a position on this type of legislation. Instead, MLMIC sees this as an issue to be determined by the New York State officials who are in charge of this area and in consultation with the professional societies who represent the healthcare providers who are most likely to be impacted by this type of law. Now I'll talk about the legal parameters around nurse practitioners and liability that may occur with regard to the actions of nurse practitioners. The liability factor is a little bit lower since some of the nurse practitioners are independent practitioners, but there's still liability to be considered. Like the PA profession, the NP profession is growing very fast. In fact, it is the fastest growing occupation according to the U.S. Bureau of Labor Statistics. And employment is expected to continue to grow by 38% between 2022 and 2032, with an additional 123,600 NP jobs expected to be added over the next decade. Where PAs were ranked number 3, nurse practitioners ranked number 1 on the U.S. World News Best STEMs job list for several years running. NPs now have full practice authority in 30 states, and more states have pending legislation. With regard to scope of practice, NPs can diagnose illnesses and prescribe treatment, but the scope is limited to a specialty area that's determined by their educational preparation and the specialty of a collaborating physician, if a collaborating physician is required, which we'll discuss in a little bit. And the specialty must be stated on their state-issued certificate to practice. NPs can also write prescriptions for medications and immunizations. They can act as first assist in the operating room if appropriately credentialed, and they may sign death certificates. Okay, let's get into collaborating NPs and the dependent versus independent NPs. NPs with more than 3,600 hours of practice may practice independently without a formal physician collaboration. This means no practice collaboration and agreement is required, and there's no written protocols to dictate what they're doing. NPs with 3,600 or less hours of practice must practice in collaboration with a physician licensed and registered in New York State and who's qualified to collaborate in the NP's area of practice. In that case, a collaborating agreement is required by law. With this type of collaboration, a collaboration agreement is required. It's called a written practice agreement, and the agreement must include certain provisions. According to the law, there must be a provision addressing resolution of disagreements regarding diagnosis and treatment. So if the physician has one opinion and the NP has a different opinion, this agreement should say whose opinion will trump. If the agreement does not address this, this is important to note that the collaborating physician's diagnosis and treatment shall prevail. Referrals, consultations, and coverage for emergency absence of the physician must also be addressed. Who is going to cover, who's going to collaborate on days when the physician is not available. The agreement must also refer to written practice protocols. So there must be written practice protocols in place, and the agreement must state where those protocols are and incorporate them into the agreement by reference. The protocols must also reflect the current nursing and medical practices in the area of certification, and they must be acceptable to the New York State Education Department. Also, the agreement must state that the physician will review patient records at least every 90 days, but this can also be a shorter period. This comes up when we get into the case study later. New York state law does not specify the number of charts that must be reviewed. That decision is left to the judgment of the NP and the collaborating physician. And some factors that can be considered are the NP's experience, the physician's knowledge of the NP's ability, the populations that's being served in the practice, and the practice setting. So there's no set number of records that need to be reviewed, but they do need to be reviewed at least every 90 days. Like with PAs, there's a limit on how many NPs can be in one collaboration with one physician. A physician cannot enter into written practice agreements with more than 4 NPs who are not located on the same physical presence as the physician. There's no limit if the NPs are located on the same physical premises. A physician collaboration agreement with a nurse practitioner does not create a supervisory relationship. Because of this, actions for vicarious liability are less likely, but the relationship is not without risk. So we talked about vicarious liability with PAs, and that is because the physician is directly liable for the actions of the PA. With NPs, especially independent NPs, this type of litigation is going to be less likely. So unlike with PAs, physicians are not automatically responsible for the medical care provided by collaborating NPs. But there's still risks of liability. So this can occur if, for example, I talked about the collaborating agreement needing to state whose decision will trump if there's a disagreement about treatment. If the physician has direct involvement in the patient care, or if the physician overrides the NP's decision with regard to treatment or diagnosis, you can see some direct liability. So, for example, assume an NP approached the doctor with a plan and the doctor disagrees and ultimately overrides the NP's decision, which is what was set forth in the collaboration agreement. That physician could be held liable for the care provided by the NP because it was more of a directive than a collaboration. However, it may be a little bit different if the physician supported the PA's decision. The physician would not necessarily have the same liability in the event of a bad outcome because that's more of a collaboration rather than a direct statement of what the physician believes should be happening in that case. So again, this is an example of why it is important to address in the collaborating agreement whose decision will trump in the case of a disagreement. Because as I said, if the agreement does not address this issue, the physician's decision will trump and put more onus for liability on the physician. Let's look at a case study involving an NP and how this can play out in litigation. So a 65-year-old male with a past medical history of prostate cancer and diabetes began treating at a neurology practice. At that initial visit, the patient saw the neurologist and complained of numbness and tingling in his hands and feet and a left floppy foot. The lab work was within normal limits. An EMG was done and a diagnosis of moderately severe peripheral polyneuropathy was made. At that point, an MRI of the spine was ordered. 4 months later, the patient presented to the neuro's office and saw the NP, this time with complaints of upper extremity tremors, which were worse with eating or writing. The MP diagnosed essential tremor, documented a plan to monitor. Importantly, there was no documentation as to follow up with the MRI that was ordered at the last visit. The next visit was 3 months later. At that point, the patient returned to the MP with complaints of worsening tremors, but the MP documented that the tremors were stable. 2 years later, the patient saw the NP again and had significantly deteriorated. At that point, he was using a motorized wheelchair. He had bladder and bowel issues, spasticity in the lower extremities, increased neuropathies, and numbness and tingling to the level of his chest. The patient mentioned at that point that he had been recently hospitalized for treatment of a diabetic ulcer. His providers were concerned that he had ALS. The MP ordered an EMG, which revealed 0 out of 5 with significant spasticity. The next office visit was 3 months later. His symptoms were still present with no improvement. An MRI of the spine was ordered by the NP and revealed a meningioma at T1 and T2. The patient was then referred to a neurosurgeon and underwent laminectomies for removal of an intradural meningioma and decompression of the spinal cord. The patient remained in a wheelchair. He had numerous hospital stays, and he passed away 5 years later. The issues that we see in this case, Deanna talked about some contributing factors, and if you look at what we see here, you can look and see where the contributing factors were in this case that contributed to liability. Neurologist stated that he didn't review the NP's notes, and nor does he sign them. It was just I don't even review them. Review is required by law, and it was also within the policy and procedure of the practice, which stated that NP notes are to be reviewed every 90 days, obviously 90 days in accordance with the law. But the neurologist stated that he didn't review the NP's notes. It wasn't his practice to do so. He also believed that the meningioma was blocked by the patient's peripheral neuropathy, but it's noted that the MRI of the T-spine that was ordered at the first visit was never completed and was never followed up. The NP also stated that she never spoke with the neurologist, and the peripheral neuropathy was confirmed by an EMG with no other differential diagnosis noted. This case was not defensible, and because of the issues here and the contributing factors, it settled for $900,000. I'm going to turn it back over to Deanna to discuss best practices to mitigate these risks and how to avoid PA and MP team-related vulnerabilities.
Thank you, Elizabeth. While there are differences in how, NPs and PAs practice at the top of their licenses, the best practices are very similar. You want to be sure to address any administrative team-related vulnerabilities, so it's important to establish that criteria for employment, looking at the education, the training, and certifications as well, doing a criminal background check, verifying references, as well as checking liability coverage. Now, while a physician expected to supervise, these professionals may or may not be directly involved in the hiring decisions. It is important to be aware of new people, promptly raise any concerns about the conduct or the quality of care that's being provided by a PA or an NP. It's important to provide orientation that's commensurate with their specialty or experience, and having that close mentorship that doesn't end after orientation. Having a solid onboarding program, and this allows PAs and NPs to feel comfortable as part of the healthcare team. It's essential, especially since some of the PAs and NPs are fast-tracked through the education programs without having had, significant clinical experience. NP programs are not standardized, and many students do complete their coursework almost entirely online. I note here a little bit, there are concerns, for PAs and NPs that received their training during the pandemic. Many had limited direct patient care opportunities, and this could impact overall ability to provide care in a safe manner. We can see plaintiffs' attorneys being all over this, when a PA or an NP is fast-tracked, looking for anything, taking that deep dive into their training, their onboarding at their facilities, their practices, or their organizations. In addition, it is recommended that even when a PA or an NP provide high quality of care and reliability, that the physician regularly check the work habits. A supervising, collaborating physician, like Elizabeth said, should conduct a periodic review of samples of records every 90 days. But consider the same process for physician's assistants and independent NPs that you may have an employment relationship with. And just being able to maintain documentation of those reviews. Supervision is going to involve more than just signing off on charts. So just ensuring that that required supervision is a regular and ongoing activity. Having an employment agreement, Elizabeth got a little bit into this, but you really should address malpractice coverage and include a stipulation that the provider obtain their own malpractice coverage and physician supervision for any activity outside of their employment. We get calls on this all the time. Coverage should only apply to those activities performed under their employment agreement. Maintaining a written agreement for supervision or collaboration with another physician when that supervising or collaborating physician is unavailable. And though it's not required, based on the present scope of practice, consider having that physician immediately available for consultation with the NP and PA, regardless of the hours of experience. Now, written protocols define each person's scope of practice. So define the role of an NP or PA in detail and cover the main types of cases that they will see. Develop and use specific criteria for your patient selection, and allow these professionals to complement physicians' work by addressing those goals of care and managing the common symptoms. Looking at when physicians should see that patient, whether it be that medical complexity, that new complex problem, any worsening condition, or maybe a critical test result has come through. So you want to outline that in detail as to when the physician would need to get involved. If you're going to establish a written protocol, like the case study Elizabeth went over, it has to be followed. Plaintiffs' attorneys are looking at that. They're wanting to know why you didn't follow the policy when the PA or NP was involved in the patient's care. And of course, education, educating the staff and the providers on the protocols, documenting their agreement to comply, document any delegation of authority to an NP or PA through a protocol, and maintain permanent records of all the protocols that you as the physician, have signed. Addressing challenges together, is going to be essential for the, successful collaboration of physicians, NPs, and PAs moving forward. Supervising physicians should schedule routine staff meetings, not only for, problem identification or resolution, but to promote education, promote that interactive relationship, and just ensure that the providers are working at the top of their licenses. Different experiences may result in more or less supervision, and regardless of the length of experience of a PA or an NP, they may have to be viewed as a novice in a new setting. And while there are policies and procedures in place, the supervisor or collaborator should be mindful of the individual strengths and weakness of the NP or PA. And of course, their interchangeability into other specialty jobs, say surgery to primary care, all should be treated with caution. Supervising physicians, should take a role in the provider's educational development, conduct annual performance evaluations, clinical competencies, even take the same CME courses. We have docs take our proactive course, and then we can set up the PAs or NPs with the same course. And just being able to show respect for the education and professionalism of the NP and PA. Now, documentation styles really widely vary when multiple providers are involved in a single patient's care, and inconsistent documentation of patient symptoms or provider's clinical rationale for treatment can result in patient care errors and create medical malpractice defensibility issues. So reviewing the PA or NP's documentation after that direct physical exam or evaluation of the patient, and ensuring consistent documentation among providers, explanations where there is inconsistency in the documentation, and just, don't sign off on the chart, without thoroughly reading it. Plaintiffs' attorneys do know how long you spend looking, at a chart these days. So, the insufficient supervision, oversight, training, is a frequently noted risk in PA and NP cases. But, the supervising physician must be available and approachable. It's not just that signature added to the record, it's creating a culture, that encourages questions, and using that supervisory time to ensure that the PA and NP is comfortable relating any doubts or questions, just that they're, like I said, available and approachable, and, sharing ideas, developing that environment of collegiality as well. It's important that these providers, are working at the top of their license. We've said it quite a bit today, but, it's going to improve clinician satisfaction, quality of care, as well as financial outcomes. And having those well-defined communication policies in place with a clear chain of command and the expectations that there's respectful and courteous communication. And of course, supporting a culture of safety where an NP or PA can speak up. And all those great tools out there, to provide feedback, that's timely, that's actionable, that's constructive. And relationships should be built on trust, trust in the NP and the PA's capabilities, and trust that the physician is approachable and willing to consider the PA's and NP's approach to the patient's care. So let the do no harm include the don't be afraid to ask questions. Once again, I thank you, for joining us. I think we do have a little bit of time for some questions if you have them. And don't forget to, take care of that evaluation once we log out of the Zoom.
Thank you so much, Deanna and Elizabeth. I welcome everyone to please, if you have questions, enter them in the chat. Or please feel free to use the raise hand feature on your Zoom and raise your hand to ask a question. And I will also put the link to the evaluation in the chat in just a few minutes.
So Deanna and Elizabeth, this is Loretta Pinessi. I'm the Executive Director for New York ACP, and I want to thank both of you for being with us today. I just wanted to give folks a chance to either think of questions or put their questions in the chat. But in the meantime, our sincere appreciation to the both of you. I know that this issue has been an issue that has raised significant conversation and discussion here at the chapter level, at our Health and Public Policy Committee meetings as well. So hopefully those in attendance, this has provided some clarification and a whole lot of other information that they were able to kind of clarify in their minds. So thank you for that. And of course, as everyone puts their questions in the chat, just want everyone to know that NYACP and MLMIC are great partners. We collaborate on a lot of activities and educational opportunities, and we do appreciate that very, very much.